full agenda of hopefully stimulating and interesting things to cover this afternoon. The main purpose of this day really is to think about some of the transformational work that senates are likely to come across during their review work and advice work. We wanted to give some time to look at perhaps things which and reflect on things from a different set of angles than we would normally. Hopefully introduce opportunities for new learning, and as with all things in the Senate world, we very much do appreciate everybody's engagement and contributions. I guess this is therefore partly about us giving a little bit back and encouraging folk to continue to support the work of the Senates, without which we would not have the quality of advice and guidance that we often provide to major change programs across the country. We do have some really very impressive speakers this afternoon, and I will front this up by saying thank you to all of them in advance for their contributions. Very much appreciated, taking time out of busy days, and look forward to hearing what they have to tell us. The rules of play today will be very much around if you have something to contribute, there will be some opportunities for Q&A at the end of each of the major segments. I do know that some speakers have to leave, and in the meantime, if there are things that you would wish to contribute, please do use the chat facility. My colleagues, Caroline, Pam from the North West Senate will keep an eye on that, and we've exchanged old school technology of mobile phone numbers just in case anything disastrous happens and I disappear into the ether. In which case, no doubt, my co-chair, Martin, will take over, displaying the Northern Lights as he is, and Caroline and Pam from our management team. So without further ado, I'm just going to pass over to my colleagues from the other two Senates, the Northern England Senate and Yorks and Humber. So Andrew, first of all, just to give you an opportunity to say a few words.
Thank you very much. Thank you for your kind words. Great to be here. And thank you very much to Caroline for all the hard work she's done. The couple of things I wanted to say are that I think in a way we're still in a phony war. We've had huge catch up to do after the pandemic. We have immense changes in terms of ICBs and NHS England, particularly in the staffing rearrangements. And I think, therefore, there's all sorts of change brewing, but people have been too busy firefighting and rearranging the deck chairs to actually look at some strategic issues. But everyone tells me that strategic issues and the changes associated with them are coming our way, and we need to be prepared. So that's why I think these days are very important for getting ready. And the other thing, just to echo Martin's comment, is to say thank you to you all, because the strength of the work of the Senate is absolutely anchored in the strength of its councils and its review teams, which is many of you here, and we're very grateful for all you do over and above the call of routine duty, and thank you for that.
Thank you, Andrew. I don't know whether is Chris Walsh online.
No, he's not here yet.
Not here yet. So hopefully Chris will join us shortly. But again, thank you to my colleagues from Northern England Senate and from Yorks and Humber Senate. We meet regularly. We have a very productive, collaborative approach to work across the north of England, and we have even more input from the South East Senate later on in the day. So you're getting overwhelmed with Senate chairs today, hopefully. So without further ado, I'm going to move us on to our first speaker, John Brown, who's based in public health epidemiology at University of Cork. I am really pleased to welcome John to talk today. I first heard him speak at a Nuffield meeting last year, and even managed to get a question into the chat, which he answered. So I was so impressed by what John has to say. I thought it was hugely important that we bring him along to this meeting to share his thoughts on getting the policy dialogue right for acute care reconfiguration. So John, over to you.
Okay, so you can hear me okay?
We can, yeah.
All right, thank you very much, Martin, for that lovely introduction, and it can only go downhill from here. So I'm going to move to slideshow, and can you see that in slideshow?
We can.
All right, perfect. So my talk is about how to frame a policy dialogue for acute care reconfiguration. And as you can see, I'm a professor at the School of Public Health at UCC and a senior editor at BMJ Quality and Safety. So why are you listening to a guy like me? Basically, I've done a lot of research in this area, and I'm one of the senior editors at BMJ Quality and Safety, which is one of the main journals in this area. Evidence is only a small part of what happens when we're forming policy, although sometimes you would imagine that the whole thing was just led by evidence. So it's important, I think, to hear from people like me, but obviously I've only got one small voice in as part of the whole process. So what do I mean by frame a policy dialogue? So first of all, who is the policy about? Who is it supposed to be to benefit, i.e. which patients, which population are we talking about? And I'm going to be speaking specifically in the talk about centralization. Why make a fuss about this? Because the whole point is clarity and honesty. From the very beginning, who exactly is supposed to benefit from this policy and how are they supposed to benefit? What is the role of evidence? And again, clarity and honesty. Is the policy honestly being directed by a clear steer from the evidence, or are we only using evidence as a kind of a crutch to get what we want? How is the policy supposed to work? So what are the mechanisms down to details, not in very vague, broad brush volume outcome terms, but all the way down to specific patients, specific conditions and specific services? Tell us how this policy change is going to lead to better outcomes for populations and patients. Is everybody going to benefit? Are some people going to get harmed, either clinically in terms of real outcomes, or in other terms, in terms of patient-centeredness, disrupted relationships, financial harms, because people have to suddenly travel a lot longer? And what are you going to do for them? Or are you going to just do nothing and just say, well, that's tough. Sometimes there are winners and sometimes there are losers. And then be honest about who might coincidentally, and I use that in speech quotes deliberately, benefit from the policy and suffer unintended harms. So people who might coincidentally benefit from the policy might be a medical school who now has much more training opportunities because care has been centralized into a facility that they're associated with. And let's be honest, to what extent was that anticipated and maybe even a driver of the process from the very beginning? And whose values get to shape all of the above? So these are the kind of things which we often talk about behind closed doors. Now I think it's time for us to bring all that stuff out into the open. So in terms of the structure of the talk, there'll be a brief review of the evidence on whole system reconfiguration, which is the stuff that I'm very familiar with, both as an editor and as a researcher. Then some reflections on the evidence base. So what does it really tell us? How might centralization make a system less resilient? So why might it not work? And obviously I'm speaking specifically about emergency care centralization. Then a couple of brief slides talking about letting the tail wag the dog and what exactly do I mean by that, and coming back to this issue of values. Now, some slides for the Danish study I'm going to talk about are taken from a presentation given by Dr. Marianne Flostrup, who published that paper in our journal in BMJQS, and they can be found at the link below if you're interested in a more full version of the presentation. So that's the paper, which came out in 2022. And in my opinion, this is the best study to date about the thing we're talking about. Remember, when we talk about reconfiguration of emergency healthcare at either a regional or national level, we're talking about a very specific, large-scale, complex intervention, which is happening at all sorts of levels and impacting all sorts of populations. So you would need a study like this to tell you if it works. What wouldn't tell you it works is some sort of correlation between volume and outcome for MI or for stroke or for aortic aneurysm or for major trauma. That is only going to tell you one tiny piece of the puzzle, that evidence, even though that evidence has played a massively large role in shaping policy dialogues. But it's only talking about a tiny proportion of all the patients who attend emergency departments. And when I talk about the evidence, I'm going to speak briefly about the contexts, because obviously it's very hard to apply evidence from one context to another. And I think we're all familiar with that. If you heard, that people had done some studies in California that demonstrated that emergency care centralization was harmful, your first instinct might be to say, well, what's that got to do with us? That we've got a different healthcare system, different population distribution, different types of services. So, here's Denmark. You can see the population is skewed very much to the east and south of the country. And when you move to the west and northern parts of the country, we have much less population, in some ways very similar to Ireland and parts of the UK as a whole. And obviously, we're talking about a much lower scale than the UK because there's only 5 million people living in Denmark. So what happened in Denmark? So they had this 2007 reconfiguration plan for the whole country. This was a whole system reconfiguration. So it led to fewer emergency hospitals accepting hot patients through mergers, closing of smaller hospitals, some new hospitals, not many, centralization of specialized treatment, those conditions which are life-threatening, but actually represent a very small proportion of the whole volume of patients coming through emergency departments, MI, stroke, major trauma, relevant medical specialists being present 24/7. So this is the decision maker hypothesis, the idea that if you don't have decision makers on site all the time, you're either slowing down processes or having worse outcomes during the night and at weekends. You couldn't get into an emergency department without. Is everybody okay? Can everybody hear me okay?
We can still hear you, John. If you're not muted, other than John, please do so. Thank you.
Okay, cool. And then mandatory referral to the ED from GP or dispatch centre. Then the number of hospitals, acute hospitals with emergency departments, went from 44 in 2007 to 21 in 2025. So think about that. That is a massive difference. And obviously that meant longer travel distances for rural patients. So here you can see in the yellow dots are the hospitals that provide acute care emergency admissions, and then the other hospitals, the smaller hospitals that aren't doing that. And you can see in 2005, yellow dots everywhere, and then 2016, far fewer yellow dots. So this type of study, in order to detect effects, either positive or negative, you have to use an interrupted time series. Interrupted time series means you can't just do a before after analysis. Why can't you just do before after? Because we know that this is typically what the pre-trend, the pre-intervention situation looks like. Things are getting better. So if things are getting better, if survival from stroke and major trauma and so on is getting better at a country level over time, why? Because of in better technologies, better training, and then you have your policy here, and you just do a before-after analysis, then it looks like your policy has worked, but things were getting better anyway. So what we're always interested in is slope change. We're not interested in before-after, because then we can't account for this pre-trend. We're interested in slope change. Has the slope been affected by the policy, and has that slope started to go in completely the wrong direction, which means that the policy's been harmful? Because remember that obviously when we're talking about mortality, lower is better. Has it made no difference? So the line just carries on straight. or has it made things better? So this is what we're looking for. We're looking to bend the curve downwards. So what were the results? Overall in-hospital mortality, absolutely no change at all. Didn't make any difference. Overall 30-day mortality, tentative evidence that it's made things worse. Okay, so not good news. Then we talk about a study that we conducted in Ireland, where we looked at case fatality ratios for serious emergency conditions in the Republic, which was a longitudinal investigation of trends over the period 2000 to 2014, using an approach similar to interrupted time series called joint point analysis. And here you see the distribution of people in the Republic of Ireland, again, about 5 million people. The darker the green areas, the less the people. So if you're familiar with the Republic, you know that these areas on the western seaboard, massively depopulated. And then you can see Dublin, obviously, Cork, Limerick, Galway, and Waterford being the major population centres. These purple areas are towns, and some of these larger purple dots would be the towns most at risk of losing their emergency department. And here's a good example of a place that lost its emergency department. So you can see here a local hospital in Bantry that you have a 24/7 emergency department. And it's been shut, or it's been reconfigured to an acute admissions unit, and people now have to travel the 82 kilometers from Bantry, which doesn't sound like a lot if you're talking about the M1, but if you've ever been to this part of Ireland, that is 90 minutes of driving time on poor roads. And that's hot ambulance driving to the regional hospital in Cork, which is a very large, good hospital. And here you can see the current ED locations, and here's the downgraded emergency department. So all of these black dots are located in parts of Ireland where there used to be an emergency department admitting, and that's all changed now. So was reconfiguration in Ireland associated with a slope improvement in case fatality for this basket of serious emergency conditions, which includes the things you'd expect, heart attacks, stroke, major trauma, and so on, but includes a bunch of other things, other life-threatening conditions like anaphylaxis and so on, that where emergency departments are important, time-sensitive care is important? And the answer is no. Again, you see curve bending in the wrong direction. Before reconfiguration, mortality was improving by 3.4% a year, going down by 3.4% a year. And after reconfiguration, going down by 1.2%. So still getting better, but that's not what we were sold. We weren't sold this curve. We were sold the curve which is supposed to be bending down. Why? Because shuttering these supposedly dangerous smaller emergency departments is supposed to lead to big population level benefits. There's also two smaller studies from the UK, one from the unit in Sheffield, Shah's unit, which looked at the impact of closing emergency departments on mortality and emergencies. This is called the closed study. And you can see here, they looked at a very small study, just looking at downgrading 5 emergency departments. And they say they found no statistically reliable evidence of a change in overall mortality following the reorganization of ED care in any of the 5 areas overall. And here's basically the only study that has ever demonstrated at a regional level benefits from centralisation of emergency care. So this looked at 3 district general hospitals in the northeast of England. And you can see the probability of 60-day mortality was reduced when 3 district general hospital emergency departments were centralised at a new high-volume emergency care hospital with earlier specialist contact. So not trying to hide anything. This is obviously very relevant piece of evidence for you guys. If I'm sure many of you are familiar with these 3 hospitals. They're located very close together. So I'm not sure that it fits with the larger model of what we're talking about in terms of, big regional reconfiguration affecting people over long distances. So this is my view. The evidence base does not support emergency care reconfigurations. So there's no evidence. Now, I should be clear, I am not talking about these single condition volume outcome relationships. Okay, we can talk about that all day long. What I'm talking about is if you just take the classic PICO approach, PICO, you've got this population, people who go to emergency departments. You've got this intervention, reconfiguration. You've got this comparison, the before reconfiguration period. And then you've got this outcomes, 30-day mortality in hospital or out of hospital. Does it work? Does the evidence support that at the whole population level for the whole group of people who use these services? So there's no evidence from whole country evaluations. Now, it's only been done really in Denmark and Ireland that reconfiguration has improved mortality. When I say done, I mean researched. The limited mortality evidence we have is not supportive of emergency care centralization. But the evidence base is incredibly weak. There are few studies with mostly weak designs other than the Danish study. And obviously, it's very hard to map from context to context. So, you know, there's some evidence around volume outcome in Canada. In Ontario, you have 14.65 people per square kilometre. In Ireland, 72 people. In Denmark, 137 people. And if you went to the UK, I'm sure it's, you know, in the same region as Denmark. So already we're talking about very different contexts. You know, Canada, Australia, incredibly long distances people might have to travel if you shut an emergency department. There is remarkably little evidence about what we call balancing impacts in implementation science. So, for example, you know, has anyone taken the care when they've implemented these policies to wonder about, has it damaged people from lower socioeconomic backgrounds? Has it been ageist? Has it damaged people from certain geographies? There's very little evidence about the timeliness of care. And then a bunch of other things which you would think would be popping up on policymakers' radars. Environment, you've got all these extra cars on the road. Is that a consideration? Staffing, has it impacted staff in terms of stress and retention? And then obviously this big concern about overcrowding and overspill at hub hospitals. So in the Republic, for example, we've had reconfiguration affecting the west and south of the country. And we've got these, we're left with these three very large hospitals in Galway, Limerick and Cork, which are now permanently overcrowded because the surrounding smaller hospitals were downgraded. We know very little about the efficiency or efficacy of mitigation measures like converting smaller emergency departments to minor injury or acute assessment units. Again, very under-researched. And obviously we know very little about the patient or care experience and the impact of disrupted relationships with local providers. So, for example, if your elderly mother broke her leg in Kerry, in one of these western counties in Ireland, and previously she'd been treated in a local hospital down in Tralee, those people in Tralee know the GPs, but they also know the rehab facilities. They know the residential care facilities that this person might have to be moved to before she can be discharged back to home. Will the people in Cork have those kind of relationships and understand where the beds are? What kind of bed would be best for this person, given her family circumstances and so on? And would they be able to call up the GP and have those conversations? Another point is that there have been consistent concerns about procedural injustice. So what do I mean by that? Poor public engagement and this focus on informing by experts over listening to a broad group of stakeholders who should have a say in these big policies which are affecting the well-being of populations outside larger cities. You do see sometimes this kind of attempt to style engagement by politicians and campaigners as populism, as though this was some sort of anti-scientific effort. I see cherry-picking studies so that policies can be sold as evidence-based, inferring whole population benefit from this small set of complex conditions, ambiguous definitions of success. So in Ireland, for example, we start out with, well, if you don't implement this policy, people will die. It saves lives. Then 15 years later, it's being sold as, well, it didn't kill anybody. You know, so and it saves some money, but that's not what we were sold. We weren't sold doesn't kill anyone. No one's going to implement a policy because it doesn't kill anyone. This is supposed to benefit people. It's supposed to lead to benefits for populations. And then I think a lack of candor about historical decisions that led to the impetus for centralization. For example, the long-term benign neglect of some smaller units, and a lack of transparency about the role of vested interests, for example, medical schools, professional bodies, staff preferences, who wants to work where. And then a lack of accountability and a plan B in the case of failure, and a lack of interest. I think a sense of, well, we've moved on. There's no point in talking about that anymore. What's done is done. And why might centralization be harmful? Let's get down to the nitty-gritty of individual cases. So it stresses the system as a whole. So you do see this problem of overspill crowding in hub hospitals. It hits condition groups where centralized care is not superior, especially difficult presentations in older, poorer patients and those with complex mental, physical, and social needs. And we know that over time, this is becoming the bulk. This is the bulk now of people who are coming to emergency departments. So let's go back to that example. Frail 80-year-old woman falls because of antidepressant-associated hyponatremia. Husband observes convulsion, possible head injury, possible broken leg. It turns out that it's the actual knee fracture is not operable. It just needs long-term rehab. Ambulance transport to local hospital 20 kilometers away, or should this person be taken to the tertiary hospital 100 kilometers away? So then that begs the question, what is the tertiary hospital going to do that the local hospital can't? And if the local hospital can't perform a CT or an CT head, X-ray, leg, review and change the meds because of the hyponatremia, stabilize the knee, transfer to community rehab hospital after a couple of weeks, why? Why can't they do that? I mean, why couldn't a local hospital do that? And what are the possible harms associated with transfer 100 kilometers away for this type of patient? An older woman, frail, depressed, living with her husband, is now in a completely foreign environment, overcrowded, busy, stressful environment with overcrowded emergency department wards, in a tertiary hospital where maybe she has to wait for a prolonged period on a trolley in the emergency department corridor. Much less knowledge of the patients themselves who may have been treated locally many times. And then obviously this problem of disrupted relationships with community care, for example, GP, local community geriatric, psychiatry, rehab facilities. And then the 80-year-old husband, he's got rheumatoid arthritis. He's on a very small income. He's on a small state pension, and he now has to drive or get the bus to see his wife, who's in the hospital for 2 weeks. Think about all the burden on him and stress on him, and it's not as though he's fighting fit. But these policies, I think, can cause harm because they're not sensitive to context, for example, different settlement patterns or changing populations, especially this problem of an older and frailer case mix that we're seeing using emergency care. And this was really nicely summed up by this piece of qualitative research by Posma, a Dutch researcher that came out about 10 years ago. And I really recommend reading this paper because it talks about what emergency departments do and why you have this tail wagging the dog problem. We focus all the time on standardized teamwork in high-tech facilities to deal with patients who are in acute danger of death or major health damage, and where the thing where we judge success is all about mortality. But emergency departments, as we all know, do so much more than that. So you have, for example, a whole bunch of patients like that patient I just talked about, the 80-year-old woman, where the main concern is uncertain diagnostics and finding out, clearing the head, finding out what's happened to the leg. And here, the big issue is not mortality risk. There might be a tiny mortality risk for some patients, but the big issue is speed of diagnosis, treatment, and admission with clear communication and patients in an uncertain situation. Then we've got these basic care issues where we just need routine medical skills, good planning, and good communicative skills. And then this whole bunch of physical, mental, and social care repertoire where we need the emergency department to have strong collaboration between home care, nursing homes, mental care, and primary care facilities for patients with either minor health issues or multi-problems, medical, psychological, and social problems. And that's what emergency departments are doing at the moment, and what they're good at in many of these facilities which we have thrown shade at over time. So moving on to the end of my talk. So I posed this question: are we letting the tail wag the dog when it comes to centralization of emergency care? So first of all, what is the reality of emergency care? How many patients attending emergency departments require high-tech life-saving care immediately? And why are the requirements of these rare conditions like major trauma, stroke, MI driving system design? Why are we starting there? Why are we saying, right, we've got to get that bit right and that bit right and that bit right? And then wondering afterwards about the 95% of patients who are attending emergency departments, because we've got this Jenga problem. I'm sure you're all familiar with the Jenga game. Once you remove certain capabilities, for example, acute surgery or ICU from a hospital, it means that the other 90% of activity, which was being done well, now can't be safely provided. Because obviously you're not going to you can't refer patients to an emergency department without acute surgery or ICU. So why aren't we starting with the 95% of conditions that don't require life-saving care? Why isn't that the entire focus when we're talking about emergency department centralization? Well, not the entire, but most of what we're talking about is those patients. And then as an afterthought, thinking about these other conditions and how obviously some care is going to be centralized for those conditions, but how that fits with this larger problem. And then obviously other interests, that's what I mean by tail wag the dog. Other interests should not drive the process. So medical school training needs, staff location preferences, all of that stuff is important, but we don't let that completely drive the process. In Ireland, I can remember pushing back on some of the centralization policies and being told, well, people don't want to work in Tralee, but that doesn't matter. I mean, obviously it's important, but what you do is you design policies to deal with that problem. You don't just say, oh, well, we're not going to have any emergency department in Tralee then. I mean, that's something which you design around. It shouldn't be driving the process. And this comes to my final slide, which is whose values should count. So within the quality and safety field, there are usually, it's widely agreed, there are 6 dimensions of quality in healthcare. And this is what the Institute of Medicine came up with: patient-centeredness, equity, timeliness, safety, effectiveness, and efficiency. Now, the field has, it's true, focused a lot on safety. So if you look at the papers we publish in the journal, 40% of them are about safety. But no one has agreed that safety is more important than effectiveness. Effectiveness here means implementing care that we know that works and de-implementing stuff that we know that doesn't work. No one's agreed that safety is more important than equity or timeliness, or if someone had that conversation, I'm not aware of it. And there are obviously trade-offs between these dimensions. For example, when you make care safer, if you are completely driven by this safetyist mentality, you make care less patient-centered, timely, or equitable. And where does the authority to prioritize one dimension over another come from? Who gets to decide that everything should be driven by safety or efficiency? So I'm going to provide you with a couple of nice quotes here. So this is a paper we published from New Zealand and by Collier et al. About the pandemic, and talking about the experience that families had during the pandemic of being shut out of end-of-life care for their relatives. And here you see a clinician saying, and if someone is being nursed in a side room, but what really is the risk? What is the risk to people coming in, agreeing to wear their PPE and masks through a corridor and then sitting in a side room with the door shut? It did seem that there was a bit of a lack of common sense, that we were actually just sacrificing a group of people for the possibility of what might be occurring with another group. And what the context of this is the idea that either the group of people outside the nursing homes or the staff themselves concerns became more important than the experience of the people who were dying in these places. And look, I'm not saying that the decisions that were made were wrong, but who made those decisions and who was in the room when those decisions were made? Whose values should count? And here you see another quote from the work we did in Ireland. And this is, I think this exemplifies this mentality of, well, we get to decide. We're the experts. We're the clinicians. We get to decide. And this is a GP in one of the regions. I think the public wants a hospital next door. They don't want to travel. They want the hospital right next to them. And if you ask the public, that's what they'll tell you. But whether that's good for them or not, I think you need to go with the expert opinion on it. So what this person is basically saying is a small group of people get to decide, and it's all driven by their opinion, as though the evidence is just going to tell you immediately what the truth is, and the values of these people won't in any way interfere with that process. Some sort of idealized evidence-based medicine approach, which we all know is not how things really operate. All right, so that's everything I've got to say. Thank you for listening.
Thanks, John. Incredibly insightful and just as challenging as the last time I heard you talk. So amazing stuff to listen to and hugely relevant for colleagues working with senates. What I'm going to do is just, there are a few comments in the chat which I'll come back to, but if we could just put hands up if you wish to ask a few questions. Let me just put up my list. First of all, got Simon Clark.
Thank you for that, John. That was absolutely brilliant, and plays to a lot of things that I was relatively sympathetic to over time. I'm just a neonatal consultant now, but in my time, at the risk of making myself sound a bit like a has-been, I have been the vice president of the College of Royal College of Paediatrics and Child Health. I have been head of department. I have been the head of School of Paediatrics across Yorkshire and Humber. This all sounds like it's an excuse for failure of workforce planning. One of the things that was utterly fascinating was I had doctors when I was the head of School of Paediatrics who would want to go somewhere, and I'm going to use some potentially vernacular English to describe this, sweaty and malaria-ridden or war-torn, rather than go to Grimsby, Scunthorpe and Scarborough. And I would say, what have you got against the children in those places? They deserve the best care. You're one of the best doctors. So go to Scarborough, be a brilliant doctor. And how do people know that they don't want to live? And I can't remember the town that you named, for example, but how do you know you don't want to live in a small town and do a rural thing if what you do is centralise all of the paediatric training programs, or indeed all the paediatric training programs? I mean, I really worry about Scotland. You know, if you go to the training program in Scotland, you end up in Edinburgh and the hospitals in and around Edinburgh, and then no one wants to work in a district general hospital. We're not training people to look after the communities that we need. It's just epically sad. We waste all this money on reconfiguration when if we'd invested it in the workforce and producing more doctors or more nurses, we could staff what we've got.
Yeah, I totally agree. I used to work at the Royal College of Surgeons and worked with some brilliant, I used to work in London, right in the heart of the beast, for the London School of Hygiene and Tropical Medicine and at the RCS with some amazing surgical trainees. And I got a lot of insight into, the incentives, structures and medical professional training. And I've worked a lot with Llewellyn Vaughan, who's opened my eyes to this stuff as well. And I think that is what it is, and someone needs to get a grip with it and understand that the incentive structures and the training profiles are not aligned with population needs. And it's what people don't understand, I think, or what policymakers are not getting, is how important those are in terms of driving what care structures end up looking like. And that is how you get these peripheral parts of the country, like these places on the south coast, in old seaside towns, which we're all familiar with. I grew up in Luton. I mean, it's not on the first place on anyone's desired destination list, I think, in terms of where they'd like to work or live. And I think without understanding that, you don't understand that basically you're making these massive decisions which are affecting, they have all these knock-on effects on how desirable towns are to live in, the economic effect of losing hospitals and so on. And these are precisely the populations that need these services the most.
Okay, I'm going to move us through questions. So Willie next.
Yeah, thanks very much. Brilliant talk and really timely, because these are the kind of things we're looking at as Senate members at the very minute. So I won't mention where, but I was going to make my point, but I think Simon made a very good point there. And I went to a talk, an education talk from somebody in Northern Ontario in Canada, the medical school, where the medical students do most of their placements outside of the hospital. And actually they have charts like you show. And when they go to work, the vast majority of them are working out in the community, not in the in the big teaching hospitals, and their scores, their progression, their grades, and etc. are even better than the ones that are working in and training only in the medical schools. My point was, I come from one of these specialties. I'm a vascular surgeon. Everything for the last many years has been driven by volume outcome, and it's related to a single condition of aortic aneurysms, which is in steep decline, whereas diabetic foot issues and peripheral vascular disease is actually going up phenomenally. So I completely get it, and I work in a non-central hospital, and we've been under this pressure for a long time, arguing the points that you've raised, and I'm so glad to hear somebody else articulate it.
Yeah, and I think, you know, what's happening though is that these idealized big hospitals end up taking these patients anyway. So the expertise has to, you know, that general expertise on dealing with these older, frail patients has to end up somewhere. And why is it not located where these people are living?
I'm just going to say one thing in response to that, which is I was wandering around the northeast of London at the weekend, and there was a sign above the fire station saying we run towards fires. And it does, I think, raise the point that we need people to be where the problem is, not where we think the problem should be. So I'm going to move on to the next question from Andy Simpson.
Yeah, you mentioned about staffing, and you can work around staffing, which is completely true. Cards on the table, I've closed one of the 2 emergency departments which I was working in as a clinical director. We could not staff that department to a level that was required overnight. Calling it something different to an accident and emergency department or an emergency department makes an enormous difference. It is now one of our urgent care centres. It's staffed with nurse practitioners overnight and GPs. They see a huge percentage of the population of Hartlepool. So people aren't required to go outside the town for a lot of their emergency or urgent care that we would normally have gone to an A&E department for, but it would have been impossible to keep going with the staffing level of staffing that we required for the last 10 years. We could only manage to staff it with 1 junior doctor overnight, and one of the situation where the GMC would have closed us anyway, because they would have removed the trainee.
Can I ask, if it was possible, would you have agreed with keeping it open?
To a large extent, I wouldn't have minded. I quite enjoyed walking to work rather than getting in the car and commuting. To be honest, it had a purpose, but it wasn't the purpose to look after some of the patients. There are a percentage of patients who are better off being transferred. And I know you've said looking at the population as a whole, and I totally agree with you. When I looked at when the Hallamshire closed in Sheffield, we did a big bit of work looking at that. And what we looked at wasn't has it improved care, but has care not got worse? And we concluded that care didn't get worse with its closure, but it was significantly better from a staffing point of view and ease of staffing.
Well, a couple of things. So first of all, I'm not suggesting that major trauma should be dealt with in these smaller hospitals. Obviously, what I'm saying is that can happen in parallel to keeping these other units open. And then the other point I'm making is that obviously in the now, I agree, you can't staff some of these units. What I'm talking about is these larger long-range policies to interrogate why that is and what are we going to do about that. And if ultimately what we're saying is, well, people are living in the wrong place, or if you live in this place, then you are now going to suffer a little bit more because of this staffing problem we have with the NHS. Then at least be open about it, and let's just talk about that openly, because we could start making the same policies for schools, for police, and for a whole range of services which are seen to be unsustainable or less efficient in remote or rural areas. But that does come back to the point I made earlier, which is, well, whose authority? Where did the authority to make these big decisions which are affecting huge communities come from?
I'm going to move on in interest of time to Prasanna and then finally to Andrew Kant.
Hello, John, and hello, everyone. Can you hear me all right?
Yes.
Okay, thank you. Two issues. I'm a really old-age psychiatrist. I've done the job for 40 years now. Start feeling it now. Two issues which concern me, and I wondered whether John can comment on both. I've been to Tralee on either, I think it's called the Ring of Cork, isn't it? Ring of
Terry.
Yeah, sorry. Now also
that's where I'm from. The case I talked about was my mother.
Dear, right. Well, that stopped me in my tracks. I've also driven in the Highlands of Scotland, and ambulances going at high speed along these country roads can be extremely dangerous. And certainly in the Highlands, there's been accidents and deaths connected with ambulances. I kind of wonder overall whether policy reconfiguration should be more directed at avoidable harm, if you like, has been the main priority. So that's one comment. And the other comment, I wondered whether John had any knowledge of any research carried out in Canada about MAID, which is medical assistance in dying. It's a bit of a long shot, and I don't expect you to answer, sorry.
No, I don't have any knowledge of that, but there are some amazing people working on rural health issues in Canada. On the avoidable harm issue, I totally agree, and I do think that these national kind of one size fits all kind of models, which are often driven by, people like me sitting in offices crunching data coming out of his, and providing these kind of very vague and abstract national level correlations about volume outcome relationships. And how can that be applied to these local contexts? Because we know that settlement patterns change so much. So avoiding harm in these situations is really important. I want to say one other thing. So me and Luella often get accused of being a little bit overbearing or overwrought when we do these presentations. I've only got one voice. And, I want to make sure you all understand that this is just one voice, one opinion, and I'm presenting what I perceive to be the evidence. But obviously, my values obviously shouldn't be the only values in the room either.
Thanks, John. And then I'm just going to allow one more final comment from Andrew Kant.
Thanks very much, John. I really enjoyed your presentation. It was gloriously and wonderfully provocative, which is exactly what's needed. Can I put a bit of context about some nuances we've seen in the north? And Andy Simpson and I have shared in the ones I'm talking about. So we were in Cumbria, getting on for 10 years ago, and there was a huge push to close down Whitehaven and get everything to Carlisle. And we drove the road between the two. We got stuck behind the tractor, and we also talked to the local Save Our Local Hospital group, which surprised them because no one had listened to them before. And we came up with some ideas about how to ensure that emergency services were kept going in Whitehaven, which involved different ways of GPs working, for example. At the same time, going to Teesside, where you have, as a paediatrician, I'm talking here in paediatric reviews, we have 3 hospitals which are in 15, 20 minutes of each other, which have full-blown emergency facilities for children, where we have some very serious things going on in terms of children not being looked after properly and lives being endangered. And I think that that's a very different situation. The push for reconfiguration there, I think, has a very strong base, at least for acute pediatrics. So I suppose what I'd suggest to you is that in certain areas, what you're saying is absolutely right. But in other areas and in certain specialties, I'm not sure it is. And I think
agree. Yeah, no, I want to make that clear. Now, Luella doesn't agree with that because she, in her experience, in the urban areas, you get just as much overspill and overcrowding damage. But in my opinion, I think there is a big case. In the Republic, for example, we closed down all these emergency departments in rural areas. There are still 9 public emergency departments in Dublin, which is a city of 1.2 million people. 9. And then there's another 3 private emergency departments. Now, why are they open? Everybody knows why they're open. There's 3 medical schools in Dublin, and each of those have their own patch in terms of training rotations. They refuse to collaborate with each other, and that drove the process. If you see the reconfiguration maps, it's 3 weird bits that are snaking out of Dublin. And that shouldn't have been what drove the process. So I totally agree. And I have been pushing over and over again for reconfiguration within Dublin. But then you immediately bump right up against medical politics when you make that argument.
Yeah, thank you.
So out of due respect for forthcoming speakers, I'm going to draw that to a halt. Jonathan, I know you've got your hand up, but there is the chat available. Many thanks to John for that very stimulating and thought-provoking presentation. Really welcome your contribution today.
Thank you. I really appreciate being invited, and I hope you have a great meeting.
Yeah, thanks very much. So we will move on to Catherine Monaghan and Gordon Elder from North Tees, who are going to talk to us about benefits and risks of digital transformation, something that I think we've all had to wrestle with over the last few years, not least driven by the pandemic. So I'm going to hand over to Catherine and to Gordon to take us through this next segment.
Wonderful. Thanks, Martin, and hello to everybody. I hope you can hear me all right. So in terms of what we're actually going to talk about today, we're going to talk about the virtual wards and what I'd prefer to actually describe as the hospital at home model and how digital can support that. I think one of the specific questions Martin asked us to answer was, how reliable is the assumption that digital and virtual solutions will bail us out? And my take on that is they won't bail us out entirely, but they can be very useful as a piece in the jigsaw. So I'm a clinician in the glorious northeast of England at North Tees in Stockton. Born there, grew up there and never really left. And I very much love working in this environment. Next slide, please. But I'm also the clinical lead for virtual wards for NHSE in the northeastern Yorkshire. So a bit of an overview, I'm going to probably spend about 10 minutes talking to you, and my view will be more of a clinical perspective and what we've done particularly locally in the Tees Valley. And then Gordon is the digital expert and he's going to come in and give you more information around that. So I'm going to talk about what are virtual wards. There's quite a bit of misunderstanding still. I personally prefer the term hospital at home because that describes what we do. We deliver hospital level care in a patient's own home or usual place of residence. What are the principles behind them and what are the key drivers and what does the data look like? And I've particularly looked at this, and forgive me for this, but through a northeastern Yorkshire lens, and then talk a little bit about what some of the problems are with gathering the data, because I think that is quite problematic. It has been and it remains problematic. A little bit about the GIRFT view, so I'm going to try and point you to some evidence. GIRFT have got a very good, clear position around the clinical evidence for virtual wards and the patient view, which is what we should always be prioritising, in my opinion. And then a little bit about the NICE view, and I can point you to the economic evidence for virtual wards that NICE have collated. And then I think we were specifically asked to talk about key enablers and where we position virtual wards in the system. My clinical view is if you stand them in isolation, then you won't get the benefits and they won't provide value for money. If you integrate them with everything else that we deliver in terms of the UCR, integrated single point of access, SDEC, rapid links into acute for patients who are really unwell, then you will get value for money. And most important, you'll deliver the best care for the patient. Next slide, please. So virtual wards, I'll just summarise this hopefully for you. They provide hospital level care at home. So we're not talking about some of the lower level but very, very vital community interventions. We're talking about patients that can be really quite unwell. And to give you a kind of snapshot, it would not be unusual on our respiratory virtual ward to see news of 6, news of 8, and we manage these patients very carefully, very safely and very effectively in the community. You've got to have rapid access to hospital level diagnostics and in some situations point of care testing where that's appropriate. And you need to be delivering hospital level interventions such as IV fluids, IV antibiotics, nebulizers, oxygen where that's appropriate. Daily input from a multidisciplinary team, and that can be in face-to-face, and a lot of our experience is with face-to-face interventions in the Tees Valley, but there's definitely a role for digital monitoring. Consultant practitioner specialist leadership, so not necessarily hospital doctors, although that's what I am. I'm a consultant in acute and respiratory medicine, but nurse consultants can be excellent, allied healthcare professionals. We've all got different viewpoints and we can all add to the overall holistic care of these patients. Next slide, please. So there's some key principles, really. The ones I'd really like to draw your attention to is around consent from patients. And patients need to have a clear understanding of what care we can deliver, what we're offering, what the potential benefits are over and above a hospital admission, because there are clear benefits over and above a hospital admission, but it's got to be patient choice. My personal experience is that patients, the vast majority of them, would choose a virtual ward above acute admission, and GIRF to back that up, that it's often patients would choose these services. And ultimately, if you've got the model right, why wouldn't they? They don't have to come into hospital. They don't have to wait for the ambulance. They don't have to go through a busy, crowded A&E. They can get the care they need in their own home. And that is very empowering for patients. It's on their terms. So we are privileged to be visitors in their house on their terms. They're not sitting in a hospital bed with a team standing over them, not dictating, but you know what I mean. It's scheduled when you get your dinner, when you get your tea, when you get your breakfast, when visitors can come in. It's a very different way of delivering care, and it's empowering for patients. Digital inclusion is vital. It's all very well and good to assume that everybody's got smartphones, but we serve a relatively deprived population. Not everybody does, and everybody who does have smartphones doesn't always have data. So we've kind of built that into our system so that we don't worsen any health inequalities. Next slide, please. So why are they different? They're named by senior clinicians. So it's not like other community services where you would be under the care of your usual GP. There's a very clear escalation process, but that can be GPs with specialist interests. In our frailty ward, GPs are the senior medical input, and that's why our step-up model is hugely effective, because GPs are very, very skilled at managing risk, potentially arguably better than a lot of secondary care clinicians. Some of these patients are really sick. Some of them aren't, absolutely true, but that's one of the reasons why it's difficult to measure the data. But some of our patients, believe me, are very, very sick. You need to be clear about who you would include without setting up too many challenges. It won't work if you only work Monday to Friday, but you do need to be clear about your capabilities and about your remit, or you may make the service clinically unsafe. Hospital level interventions, I've already said, and daily clinical input. And that doesn't necessarily mean, for example, on our frailty ward, you've got a GP who runs it. If they need specialist support, they've got direct access to the consultants in the hospital who will be able to provide that support virtually, really. Next slide, please. So the key drivers, very, very patient focused, in my opinion. It's about patient choice and patient centred care, right place, right time, and care closer to home. The economic argument is different, but I think it's difficult, personally think it's difficult to argue with those as clinical kind of priorities. We know, and I'm not a geriatrician, but we know that frail patients do really badly in hospital. We can lose your walking stick, we'll lose your hearing aid, we'll get your medication wrong. None of that happens in patients' own homes. So that's what we're trying to address. And we all, I don't think we need to emphasise any further, the system is overstretched. Next slide, please. There are different models of care, and this is one of the reasons why the data is really, really difficult, because you're not comparing like with like. Some of them are primary care delivered, some are secondary care. My personal view is that the best services are integrated, fully integrated, with joint responsibility. We have a memorandum of understanding with our GP Federation. They deliver the care, but it's joint governance with very close links to specialty consultants if that's required. Technology enabled, Gordon's going to talk more about that. Some models are largely home monitoring, some are much more face-to-face. We've set out much more face-to-face, but we are now embracing digital because it will enable us to increase the remit of the care that we deliver. And integration, I couldn't emphasise this more clearly, it's absolutely vital. This is a team sport looking after these patients. There's no point thinking you can look after frail patients in the community if social care aren't involved from the word go. So they're a key part of our local steering group. There's no point at the end of a 6-day spell saying we need an increased package of care and social care saying can't deliver it. So the patient comes into hospital for all the wrong reasons. It's got to be integrated with ambulance service. So in the Tees Valley, we use NIAS, but there's NWAS and obviously NYAS and other ambulance services. They can refer directly into our services. They can go through 111, can refer directly into our services, or they can go to our integrated single point of access and they can refer directly into our services. If a GP phones to say I need a hospital bed, the bed bureau is in the same place as the virtual ward team, so the on hold while they're waiting to get put through, which we do prioritise them, says, we've got a virtual ward, would your patient benefit from this? This is what we can deliver. So we try to prioritise it in all referrers' minds that this could be a better option for their patient. Voluntary sector, we still quite haven't got that right, and we're working on that. But mental health services, so we've got a practitioner from TUV that sits in, so they can support around the delirium aspect of some of these patients. And the UCR, these are the same patients. So we can dispatch a 2-hour urgent community response to a patient who might think these are perfect for the virtual ward, and they would just step them directly up into those services. The patients do not have to come into the acute trust. Next slide, please. Again, Gordon's going to say more about this. This is the NHSE view, that they should be enabled by technology, which includes, as a minimum, patients or carers to be able to input agreed data. And this is very much a horses for courses, one size does not suit all. You can get them so the Bluetooth to a central dashboard, or patients can input them themselves. And then the clinical team, ours is done in our iSpa, can monitor it remotely, and the system alerts if a patient moves outside of their recognised parameters. Next slide, please. This is just to give you an idea of what's happened in NEY. So this is a snapshot from December 2023. Busy, difficult, but not as busy and difficult as December 2022. Certainly not in our trust. And you may have a different view on that, but I definitely feel it was better. But we've got 780 patients in virtual beds across NEY, which I think is about 5% of the whole capacity. And this is a programme where in some places it came from a standing start in about 21 where there was nothing. So we've really tried to expand that. Next slide, please. So this is where we start to move on to the kind of evidence. What do recognised national bodies say about virtual wards? As you probably tell, I'm very passionate about them, but I'm also quite realistic. And I think it's been helpful to have GERF to back up some of this. So over 99% of patients would recommend the service. That's pretty powerful, actually. And again, as I've said, why wouldn't you? You're getting the care you need in your own home. There's really good evidence for avoiding harm, so much less likely, understandably, to acquire an infection, and we know how debilitating and damaging hospital-acquired infections been. 8 times less likely to experience a functional decline, and much more likely to end up in the usual residence without an increased package of care. So why would social care not be in on this? Because their budgets, like health budgets, are very, very, very challenged. So GERF are very clear that we can avoid potential harm and much less likely to be readmitted. Next slide, please. So what did I say? I'm sorry, I haven't been IT savvy enough, ironically, to put a link in there, but NICE did a piece of work looking at 15 virtual wards, and they're on an economic basis. This just gives you an idea of the type of thing that NICE looked at. And essentially they found that 13 out of 15 services reported that there was an economic benefit to being on a virtual ward, including one of my friends and colleagues from the Northeast, Dr. Echevarria. They did a piece in Newcastle. Some of the services were international, and then it becomes more difficult to compare. And NICE do describe the difficulty in comparing, and hopefully I have briefly already, that services are so different, it's really difficult to compare. But Carlos's service, for example, showed a £1,000, it cost £1,000 less to treat a patient in his virtual ward than it did in an inpatient setting. So NICE do say that 13 out of 15 studies they looked at suggest an economic benefit. I think the vital part of that is the integration in the system. So if you're just using them as step down with small numbers, then you're not going to get the financial benefit at all. You'll still get the patient individual benefit, but you won't see the financial benefit. Next slide, please. So key enablers, and I think I'm nearly finished now, they've got to be integrated within the system. And I think I've probably emphasised that enough. Our pathways have fast tracks into our acute admissions unit, so patients don't necessarily have to come back through A&E. And I'm sure Andy, as one of our A&E clinicians, may be able to corroborate that. Occasionally they do, but ultimately we do have some empty beds in our medical admissions unit. Not all the time, and Andy's laughing, but sometimes patients do go through A&E, but that's hopefully much less common than in other areas because they've got direct admission rights to our medical admissions unit. Or 24-hour, 7-day-a-week integrated single point of access with at least a band 6 clinical triage nurse for escalation. So the out-of-hours teams, if needed, can escalate and they can give advice. And I think that's absolutely vital. If you stand them alone on a Monday to Friday, 9 to 5, it's never going to work. You need very strong clinical leadership with people who understand it and who are able to share the risk and who can understand the risk. When I led the service, I don't clinically deliver it anymore, would at any time probably have about 50 patients under my care in the community. And it never caused me any concern because the team are so strong and the leadership that the team give is absolutely fantastic. So if they're worried, I'm worried. If they're not worried, then I'm not worried. But you really need that because people otherwise won't understand the risk. And very strong financial and clinical governance. Next slide, please. So a very final slide, I promise. North Tees and Hartlepool Respiratory, we set up in 2016. We've got very large numbers. To give you an idea, 350 patients a month on average in the winter will go through our service. Very low admissions rate. Qualitative data, the patients absolutely love it. Quantitative data, about a 50% reduction in our mean length of stay for COPD and an absolute reduction in admissions for COPD. Other things have happened in that time, and it's difficult to attribute it all to the service, but actually patients very well describe, I would be in hospital if it wasn't for this service. There's a link which NHSE did, which is the patient's perspective, and I would advise you all to watch it because Miriam describes beautifully what we do. The Frailty Service is a full collaboration across primary, secondary and social care. There is a daily MDT talking about these patients and about how we can best support them. And the only person who's not in the room, who I think should be, is the patient and or their carer if they want to be. Everybody else is in the room. So there is a full whole system approach to managing this. And they've got to be supported by a 24-hour ISPAR. Thank you. That's all I've got to say.
Thanks, Catherine. Is Gordon going to contribute further? Or
Yeah, he's got slides.
Okay, over to you, Gordon.
Okay, so good afternoon, everybody. I'm Gordon Elder. I'm the Regional Chief Nursing Information Officer, or the digital lead for virtual wards. So very happy to go through some slides. Going to take you very quickly through about virtual wards technology enablement, what that actually means, and then some things further about digital transformation and things as we need to consider as we move forward. Kath absolutely got it right at the beginning. From the very beginning in our group, in the regional group, virtual wards had to be clinically led, technology enabled. Next slide, please. And the virtual ward tech definition that came from NHS England was very clear. Patients need to be able to input data in various different ways. There needs to be a platform in relation to where clinicians can review a trend and look at vital signs. And thirdly, an alerting system needs to go in. Next slide, please. When we started to do the original scoping, there were 96 different companies in the UK who offered this type of solution. So tendering was very long for many of our 4 ICBs within the North East and Yorkshire. But there was very clear things that we had to do. Vital sign entry for us, we've looked and talked about, and also trend analysis for clinicians. Questionnaires about how patients are progressing on multiple different things needed to be added into there. How do you prioritize and configure alerts? So patients who have long-term COPD, setting that their SpO2 target at 98% is unrealistic. How do we make sure that we have configurable alerting so the clinicians know who to prioritize? Sharing and integration into the EPR. So how are we making sure that data is shared with everybody who's on that clinical pathway for that patient? Teams involved in access, multiple teams, not just the virtual ward team, district nursing, CRRT, the HAT team, acute team, primary care, everyone needs to be able to access and see what's happening with that patient. And then clinical recording and video conferencing so that we can actually make it easier for patients and for staff to have multiple contacts with that patient. Next slide, please. This is just an example of how one set of virtual wards is set up, vital signs going in, and there's 3 different ways to do that. Manual input via device, for example, a phone or a tablet, or using Bluetooth technology. So an SpO2 monitor, SFIG, and thermometer will all be connected to that device via Bluetooth, and the patient doesn't even have to enter that. We would set time frames for when the patient do it, whether it's twice a day, 4 times a day, whatever we think is necessary for that patient at that time for their clinical condition. And then thirdly, there's continuous monitoring or wearable devices where you can continuously monitor patients over a longer period of time and monitor ECG, respiratory rate, temperature, and you can also track patients. Now that has a whole new IG implication about tracking patients, but some of these devices do offer falls protection and falls alerts. So if a patient did have a fall, we would be alerted. Next slide, please. This is examples of some of the kits and the basic kit that will be provided. This has gone through lots and lots of testing and trying to refine what is best for those patients. But the basic kit is general for most patients and will have a SPIG thermometer, pulse oximeter, scales, and then questionnaires built into the platform. But there's also patient-specific kit. And as we continue to develop technology, more and more specific kit can be available. And point-of-care testing is absolutely one of the things that's being looked at. But when implementing these types of devices into patients' homes, we need to figure out how many do we need. So when a patient is discharged, how quickly do we get that equipment back, get it cleaned, get it tested, and get it ready to go out? So if you've got 50 virtual ward beds, you probably need at least 100 sets of devices to make sure that continuous flow is there. How will you get them to patients? We can do this through post, delivery, volunteer service. There's lots of things to consider from an operational point of view. How do we clean them and what do we clean them with? What happens when they break? How do we replace them? Do they need calibrated? Do they need tested? And then staff training. Are our staff feeling confident and comfortable with the devices that we send out that they can tell patients how to use them? Next slide, please. Other things that we need to consider about is what multiple solutions available, and there are lots of them out there that offer lots of different things. On the right-hand side of that picture, you see a person's face being scanned. On my phone, I have an app that uses the camera that will tell you the patient's respiration rate, their heart rate, their blood pressure, and later on this year, their blood glucose purely using the phone on their camera. It uses light refraction from the eyes and from the skin to tell us this data. So you could be doing a virtual consultation with a patient, and at the side of that screen, it's automatically recording all their vital signs. So this is technology that's happening now and is currently going through testing. When we tested it, it was incredibly accurate, actually, but it does depend on what type of your light source. So there's lots of things to consider. But how do we do about interoperability, making sure that is there, resolution of problems when something goes wrong, and also the clinical expectations of the devices that we're using, because these devices are not ITU grade or theatre grade monitoring devices or Dynamaps. They're normal devices that can usually be bought over the counter, and we need to make sure that there's a tolerance in relation to clinical staff understand that. Patient education, how to use them, and the last one I'll put on here is one of the big problems that has been highlighted that was completely on no one's radar is chargers. All of these devices have a completely different charger, and it is causing a bit of a nightmare. Next slide, please. When looking at the wider digital transformation agenda, there's lots of things we need to consider when we're looking at patients and how we interact with patients. And there's multiple things on this list that must be considered at the time of any project initiation and going through that project plan. What's the connectivity like? What's the digital skills of the patient? Confidence of the patient, the motivation of the patient, the design and awareness. And not everybody's aware of digital services that are available. But a key one for me, and one that keeps coming up, is staff capability and capacity. So if staff don't understand how to use technology, how do we expect them to teach patients how to use devices and use technology? But more importantly for me, as I'm sure will resonate, is staff need that capacity and time to spend with patients to teach them how to use devices. And at the moment, as we know, services are very stretched. Next slide, please. For those of you who are a bit, I'll not use that word, wiser, like me, you'll remember Woolworths. So one of the things that Pick and Mix is about is that we must be ensure that technology is used and we provide multiple solutions for patients. We must give them understand where patients are in their digital journey, their digital maturity and what they understand. But we also must, and something that's often forgotten, is where are patients on their clinical pathway? Let me give you an example of that. I am very technology enabled, as I'm sure you can imagine. I'm a bit of a tech nerd. I want all my information to come through on my phone, my computer. I want my appointments to appear on my calendar automatically. However, if I was referred in on a 2-week cancer pathway, I most certainly don't want a virtual consultation. I want to be sitting in front of my consultant in a clinic. I want to be there at various stages in my pathway. So we must consider from a digital transformation point of view, not only where our patients are from a digital maturity point of view and where their confidence is, but also where are they on that clinical pathway. And we must adhere to that, and we must take that really seriously. Next slide, please. This is the last quote that I'll leave, and Kath did allude to digital inclusion. It's so important that we make sure we include all of our patients. Virtual wards is incredibly important and can benefit patients greatly. I would be first in the line with my hand up to say that I would like to go home early and recover at home. But if you don't have the capacity or the connectivity or the digital enablement to do that, why should you be excluded? And that's just one example across lots of digital transformation programs. We must include all of our patients and give them the opportunity and the options that are provided to everyone else. That's me. Thank you.
Thanks, Gordon. And to Catherine too, incredibly important. I suspect as Senates, increasingly we will be required to know more about and to consider digital solutions as we go forwards. And just a personal observation, Gordon, I'm absolutely mind blown by some of the things that you've mentioned there. So I'm going to very quickly, in the interest of time, just allow a couple of questions, firstly from Jonathan.
Yeah, thanks. So there's a couple of comments actually. So first, thanks both of you for 2 great summaries of work that I'm very close to. My first observation is as a medical director for NHS England, and you will recall that virtual wards came into the collective consciousness, and I don't mean in North Tees and in the area around it during COVID, when we recognised that our bed base, which was not sufficient and still isn't sufficient, was becoming even less so, as we had about 4,000 patients with COVID in our 16,000 bed base across northeastern Yorkshire, and the 2,000 or so who are medically safe for discharge, which remains roughly around that figure today. So an eighth of our inadequate bed base is already occupied by people who could be dealt with elsewhere. Now, what is different about North Tees is the service they provided, as Kath mentioned, is they've been doing this since 2016, and it's a much more mature service, which is a really good example of what you can do, but it takes time and effort. So other areas that are not delivering in the way that we are, or you are in North Tees, you know, there's time, it takes time to do this. So just from a GP, because I happen to be a GP in the catchment area of Cath's Hospital, so I've watched this develop. And a few points worth saying. Firstly, I've never met a patient in 27 years as a GP in Stockton with some of the most deprived patients in England who wants to go to hospital, or almost never. So you're already pushing at an open door with regard to that. The second thing is hospital-acquired deconditioning, which is a new condition that I wasn't taught about at medical school, is very real. And as we have an older, more multi-morbid population, the impact of stay in hospital becomes ever more evident as patients don't achieve anything like the degree of independence that they had before being admitted from something as simple as a UTI. And virtual wards help mitigate against that. And thirdly, just a comment about health inequalities. So Kath and I deal with some of the most deprived people, as I've mentioned, and tech kit is provided, but it is incredible the level of support from relatives and families for patients who can be admitted into the virtual ward. And you know, the level of care generally from families, I find, is way better in some of these poorer communities than it is in some of the more middle class ones, where they're more inclined to say, oh, just crack on with it. So I've never had a problem with this issue. And then the final point, because I've talked far too long, is having the confidence of general practice and primary care that this service is safe and the lines of responsibility are absolutely clear. Because as soon as there's a scintilla of doubt about that, then the default position for safety conscious GPs is likely to be an acute hospital admission, when it might be a better way of dealing with it for everybody, for the system and patients alike. So, you know, this is not the answer to all the NHS's problems by any stretch of the imagination. And one of the faults at the outset was this was badged as kind of, you know, this is how we're going to save ourselves. It isn't, but it is one of a number of things that I think well, it is very much so helping to turn the dial a bit where we need it to get to. Thanks very much.
Thanks, Jonathan. Your comments have been welcomed in the chat as well. And I think they really add a lot of emphasis to what Gordon and Kath have already just outlined. So I'm just going to finish up with final comments or questions from Paula.
Yeah, thanks, Martin. It's more a comment. Hi, Catherine and Gordon. I'm Paula Cowan, Northwest Regional Medical Director for Primary Care. And like Jonathan, I'm a jobbing GP, work all day Monday and all day Friday in primary care, in general practice, I will say, and took the easy days of the week. So I'm totally sold on virtual wards. And before this role, I was joint clinical lead for the Hospital at Home programme with Sarah Sibley, who's a respiratory. Yes, I thought you might recognise the name. Yeah, fab girl. Just a couple of things about virtual wards. You know, it's just really echoing what you, Kath, and what Jonathan has said. Patients decompensate so quickly in hospital, and then they're not allowed home because they can't do the stairs. The physio won't let them go because they can't do the stairs, but they live in a bungalow and they've never had to do the stairs in 20 years anyway. So, you know, and they can't go because they can't make a cup of tea in a completely strange environment. Well, don't come to my house because I can't make tea either, you know. So, yeah. You know, there's a silly reason for keeping people in hospital, and then they're decompensating more, and then there's social care, you know, placements being looked for. Confidence of GPs in community services, yes, but also confidence in community services and in virtual wards from our ED colleagues. The amount of patients who are admitted through ED who I feel, I say, but but send them home and we'll get the community team to see them. So we need to share the learning and share that confidence across all of our services so that an ED colleague can say, actually, no, we'll send you home and the respiratory team or the virtual ward will get you into a virtual ward so that you can be seen and managed at home. So having confidence in those services. Point of care testing is something I'm hugely passionate about, and I sit on the Northwest Point of Care Testing Board, and we're looking at how we get that into the acute respiratory infection hubs. So getting that into virtual wards will be a game changer as well. And family support, I completely agree. Actually, in terms of tackling digital inclusivity or exclusivity, a lot of the time families are very, very happy to support their infirm loved ones in managing and addressing that, and they'll often then present to us with a spreadsheet of blood pressures and SATs, etc. And Jonathan's laughing. I've seen that time and time again. So thank you for what you're doing. If you don't mind, I might reach out to you offline. So I really appreciate the presentation. Thanks.
Thanks, Paula, and thank you to Gordon and to Catherine for the presentations. Compare and contrast with some of John's earlier comments around centralisation and bigger hospital. This is about bigger community, I guess. So really stimulating sessions. We will be sharing slides with permission of presenters after this meeting for further distribution and consideration. So thank you to those who've contributed both in the chat and verbally so far. We are running slightly late. I do not make any apologies for that because this is all rich stuff. If I can grant us permission to a 5-minute comfort break for those who need it, hopefully that's enough to get comfort. And then we will reconvene at 3:05, if that's okay.